So good afternoon. Welcome to the Plenary 5. This is the final session to conclude the 30th International Conference of Health Promoting Hospitals and Health Services. I'm Yuko Takeda, a professor at the Juntendo University School of Medicine. So this session is co-chaired by Dr. Marian. Would you like to introduce yourself?
Yeah, thank you so much, Yuko. Nice to see all of you for this last session. I'm Marianne Aucher. I'm the coordinator of the French HPH network, and I'm also a GB member for the International HPH network.
Yeah. Okay, so just to refresh your memory, this conference started on Wednesday evening. I feel like it's a long time ago because it's so productive. Anyway, so in the plenary 1, we had Professor Fran Baum and Professor Richard Wilkinson to set the scene. The plenary 2 took off on Thursday morning. We discussed strategies to address and improve health equity. And in that afternoon session of plenary 3, we learned approaches to improve health equity through social interventions in Canada, good practice in Japan, and social prescribing in Malaysia. Then this morning, we learned how to work with and within the community to promote health. The roles of pharmacists, community initiatives, and outreach activities in rural areas of Japan were discussed. So now it is time for the final plenary. We will discuss the role of HPH networks in promoting equity beyond the health sector. There will be 2 keynote presentations, followed by comments and opinions from 4 distinguished panelists. So now I'd like to introduce the first keynote speaker, Dr. Takeo Nakayama. So Professor Nakayama is a distinguished faculty member at Kyoto University, specializing in epidemiology and evidence-based healthcare. With his wealth of experience and expertise, Professor Nakayama has made significant contributions to health promotion in Japan. His work has been widely recognized in the academic community, and he continues to inspire and mentor students and researchers. So, Professor Nakayama, please start.
Thank you very much for our introduction. Hi, everyone. Welcome to the final session. It's a great honor for me to make a keynote speak of this session. I'm Takeo Nakayama, Kyoto University, and I'm the consultant on Japan health promotion, promoting health hospitals and health services. And I will talk about the equity in health and the role of hospitals, perspectives from Japan. And I would like to begin with the Constitution of Japan. Just after the World War II, the Constitution was established. And as you know, Hiroshima, where we are now, along with Nagasaki, are symbolic cities in ending the war. And this is the preamble of the Constitution. We, the Japanese people, desire peace for all time and are deeply conscious of the high ideals controlling human relationship. And we have determined to preserve our security and existence, trusting in the justice and faith of the peace-loving people of the world. We desire to occupy our honored place in an international society, striving for the preservation of peace and the banishment of tyranny and slavery, oppression, and intolerance for all time from the earth. We recognize that all peoples of the world have the right to live in peace, free from fear and want. And this is the Article 25. All people shall have the right to maintain the minimum standard of wholesome and cultured living. And in all spheres of life, the state shall use its endeavors for the promotion and extension of the social welfare and security and of public health. Under this constitution, Japanese people have made a lot of efforts. This is the life expectancy world ranking, as you may know. the Japan is the top country, men and women. And for men, the second, and the women, the top. And this is the vital statistics of Japan. There are 1.6, approximately 1.6 million deaths per year. And the top leading of cause of death is malignant tumor, followed by heart disease, senility, cerebrovascular disease, and pneumonia. And on the other hand, birth, approximately half of the number of deaths. And healthy life expectancy is 9 years shorter than average life expectancy for men, and 12 years shorter for women. It means that many people need long-term care before dying. The cause of long-term care is, number one cause is dementia, and the second stroke, the third is senility. And this is the life expectancy by prefecture. Life expectancy itself differs by about 3 years for men and about 2 years for women between the longest and shortest prefectures, respectively. This slide shows the population pyramid of Japan. It is very interesting. 1950, pyramid with a large population in younger age group. And the 2014, the pyramid disappeared. And 2060s, it is projected inverted pyramid due to aging society with fewer children. This is our society. And Japan has a universal health insurance system, as widely known, and which all citizens are covered by medical insurance. We are proud of this system. This system keeps out-of-pocket medical costs low and guarantees access to a wide range of medical services. Insurance is broadly classified into 2 categories: for company employees and civil servants, and for the self-employed and unemployed. Japan's healthcare system guarantees universal access and contributes significantly to Japan's exemplary health outcomes. The system was launched 1961. I was born in this year, so I'm the same age. And Lancet, 13 years ago, the Lancet published a special issue titled Japan Universal Healthcare at 50 years. This report gives high marks to the country for becoming the world's longest living nation in a short period of time and achieving a high standard of health, achieving fair and accessible health care with universal health coverage, and achieving these goals with healthcare costs that are among the lowest in the industrialized world. This issue have encouraged many researchers in Japan at that time. And editor, Dr. Richard Horton, his father was stationed in Hiroshima after the war and had a great fondness for the devastated city and the reconstruction of Japan. And Dr. Horton himself was influenced and developed an interest and respect for Japan, he said. But he indicated 2 weaknesses to the Japanese healthcare system. However, this system faces significant challenges primarily due to aging population, changing employment patterns, and bureaucratic inefficiency with its 3,500 insurers. To improve efficiency, it is suggested to consolidate these insurers at the prefectural level. It is not realized at present. And another weakness is in primary care, particularly in managing chronic diseases and insufficient training for primary care physicians, which hampers effective patient care and overburdens higher level medical facilities. And he stressed that a specialty for general physicians should be established. This slide shows estimate of national medical care expenditure. It is surprising. And 63 years ago, universal health coverage was introduced. And this is our latest data. For fiscal year 2023, 310 billion US dollars, 47.3兆円 in Japanese yen. And medical facilities in Japan, many facilities are operated by the private sector. This includes private clinic and large private hospitals. In particular, there are many high-quality private hospitals in urban areas. Presence of national and public medical facilities. On the other hand, national and public hospitals and university hospitals also play an important role, providing high specialized and urgent care, education, and research. So, Japan's systems is characterized by universal health coverage, which provides broad access to healthcare, while private and public health facilities complement each other. This slide shows the medical facilities by establishers. Medical corporation privates are majority. This picture is one of the university hospital, Kyoto University Hospital, big one. And this is a community hospital, Kyoto Minren Central Hospital. And these are typical clinics in Japan. And at this clinic, I was working as a part-time physician 30 years ago, my dear old days. And if you want to know more about health and healthcare in Japan, these books are recommended. And the right one is edited by Professor Katsunori Kondo, a very great book. And next, I want to show the Medical Practitioners Act, Article 1. Medical practitioners are to contribute to the improvement and promotion of public health through the administration of medical care and health guidance, and thereby ensure the healthy lives of the citizens. This slide shows I have been involved to develop the model curriculum for medical education. This is the essentials of the medical education for young doctors, future doctors. We set the competencies required for future doctors. But these competencies are not only required for future doctors. These are required for us ourselves. First, professionalism and a comprehensive view of people living with illness, lifelong learning, scientific inquiry, problem-solving skills based on expertise, ability to utilize information science and technology, clinical skills for patient care, communication skills, interprofessional collaboration, and understanding the role of medicine in society. I would like to add some information to understanding the role of medicine in society. Recognizing that the medical care is a part of society, we will strive to provide fair medical care and improve public health as a voice for health, while also considering economic, regional, and international perspectives. And social views are emphasized. There are many issues, problems, difficulties to be tackled. And I want to back to the history. There was a destruction and destruction. We know the power of humanity. This is the last slide. Professor Takeda has overviewed and overview of plenary session. There are very, very fruitful sessions we have experienced. And we are now approaching the number 5, the role of HPH networks in promoting equity beyond the health sector. Let's start the final and wrapping up session. Thank you very much.
So thank you very much, Professor Nakayama. The floors, if you have any question that you really have to ask for clarification at this moment, please do so. So. I have been chairing the session like this is the third time, and the audience has been very quiet. So you sure? Yes, I think so. We can move on.
Okay.
Yeah. Thank you very much.
Thank you very much.
Yeah. Now I'd like to call the second keynote speaker, Professor Shu-Tae Cho. Professor Cho is the founder of Taiwan Network of Health Promoting Hospitals, and we are very much impressed that she promoted the Taiwan HPH to become the largest health promoting hospital in the world. Professor Cho served as a former chair of the Governance Board of International HPH Networks, and she's currently a chair of the International Task Force on Health Promoting Hospitals and Age-Friendly Healthcare. She's an elected member of the Global Executive Board of the International Union for Health Promotion and Education. So her career is so extensive that without further ado, could you please start, Professor Cho?
Thank you, Chair, for your kind introduction. And dear colleagues, it's always my greatest pleasure to participate in the annual conference of International Health Promoting Hospitals and Health Services to meet the dearest old friends and also to meet with new friends. And my role here is to talk about fostering equity and well-being through HPH networks, what needs to be done, and especially the scientific committee would like me to talk about the works beyond the health sector. So how do we collaborate and reach out to the other sectors to tackle determinants of health? I will briefly talk about global policy context for health equity and determinants of health. And then I will talk about what do we need to know about determinants of health after this wonderful conference, and then some examples of what can be done, and then my final recommendation. So regarding global context, we know that in 1986, in the first global conference for health promotion, WHO defined health promotion as the process of enabling people to increase control over and to improve their health. There are 3 keywords here. It's about people, which means everyone, not only your patients or the persons, it's the people. And then it's about the control of their health. And it's about enabling the control of the health. So you see, there must be something about the control of our health. So in Bangkok Charter, they decided to make it explicit to include these words, the determinants of health, into the definition of health promotion. But actually, still, by speaking of enabling, it's not only empowering, it's enabling. It's not to make you more powerful, it's to make you being able to. So it might be making the tasks easier so that you can control them. So regarding the contributors to ill health, you can see according to US analysis, health behaviors accounted for 30% of health outcome. clinical care, despite of our greatest efforts and devotions, accounted for 20%. What are the others accounting for the other 50%? Social determinants of health and physical environment, which also sometimes we say environmental determinants of health, they accounted for 50%. So how to improve health equity? Many plenary speakers have mentioned that in WHO 28 reports, they listed 3 overarching key actions. First is to improve daily living conditions. Second is to tackle the inequitable distributions of power, money, and resources. And third is to measure and to monitor the progress. But is there anything within our jurisdiction of everyday clinical services? Seems no. But does it mean we don't need to do anything and just wait to see more and more patients with more and more diseases? What should we do? So, and the first thing is to measure and to communicate. So, for example, in 2015, we collaborated with Sir Michael Marmot to produce the first national report of health inequalities report. And so based on that, we can engage the top politician, the president, to sign and say he would like to support health in all policies, communication, and collaboration. So data talks, and we need to work together to have data and use the data. And then in the forwards, I mentioned that we need evidence and transparency to ensure accountability, and also it's a global goal and it should be a domestic goal, and we need to have the commitment from the top, but we also need to work with the community so that people are engaged and people participated to support. And actually the UN 2030 Agenda for Sustainable Development pledged to leave no one behind, which means they are working on economic, social, and environmental determinants to improve equity. So we are in line with this global policy, and your efforts and your voices will be very much meaningful and valuable to the society. And the new general program of WHO's work, 2025 to 2028, regarding health promotion, there are 2 strategic objectives. First is to respond to climate change. And second is to address health determinants and the root causes of ill health. So you can see it's the current actions that WHO would very much like to do, and it says that we need to work not only within the health sector, but we also need to collaborate beyond the health sector. So again, it's about the control. And so as Dr. Funakoshi mentioned, a micro level of intervention, meso level of intervention, and macro level of intervention. We work at the front line. It's the micro level of intervention through your services. However, in terms of population impact, it's labor intensive, but the impact is limited if we do not address the upstream social and environmental and commercial determinants of those things. So in addition to working on micro level, we also need to pay attention and to communicate with meso level interventions, and also try to engage macro level interventions. And you see that this year, Lancet Commission on Liver Health, their report said they need a call for action to shift the orientation in tackling liver disease. And they show in the picture, the area shows the contribution from different factors. And again, likewise, it's the structural dimensions, the social determinants, the environmental determinants, commercial determinants, and political determinants of health, they contributed a lot. So those intervention at the macro level is important. And for alcohol and virus, they also need to look at population level policies, such as rising the price of alcohol, such as mass vaccination program for all. And actually, the influence of health determinants bears three characteristics. The first is that it's beyond the individual control, so we need to work with the other sectors to help. And the second thing is the phenomenon of syndemics. These adverse conditions, such as low-income, poor housing condition, and smoking behavior, that tend to cluster and interact. And they cluster and interact throughout all stages of people's health status, including the occurrence, the detection, the delayed detection, delayed treatment, and poor outcome. And they shaped a vicious cycle that poverty leads to ill health, and ill health exacerbates poverty, and then the health was even further worsened. But the good thing is we can break the vicious cycle and create virtuous cycle. I will not go into the detail. I can use breastfeeding as an example for virtuous cycle. Recently, a hospital in Taiwan, due to shortage of nursing workforce, they would like to shut down their baby room and to push all the babies and mothers to practice rooming in. What will happen? They practice baby-friendly hospital initiative. They reallocate nurse workforce to support breastfeeding counseling before and after delivery, etc. More mothers might initiate breastfeeding, and in this way, for more babies to be exclusively breastfed, we reduce carbon emissions from cows, containers, infant formula, etc. And the poorer mothers wouldn't need to spend money to purchase infant formula. And the mothers and children, they are healthier in the future. And the burden to health system will be smaller further. So there are co-benefits, and they shape the virtuous cycle. But it is good for initiation of breastfeeding. If we want to prolong breastfeeding to 6 months, then we need meso-level interventions like lactation rooms in the workplace and in the communities, and also the support for longer maternity leave. And in our analysis, these are all associated with higher success rate of breastfeeding up to 6 months. And we managed to achieve the 2030 global target. Actually, earlier, we achieved this target in 2012. So, and we have the support from the frontline people, as I mentioned here, Dr. Zhang Tendai and Yang Wenli. So you work at the micro level, but you can leverage your influence and your support to meso level and the macro level interventions to make these things happen. And for tobacco control, likewise, likewise, the macro level intervention will create a better result and also better equity. And for age-friendly city initiative, so in addition to age-friendly healthcare accreditation, we also do age-friendly city initiative. And now we are doing this in the parliament. We have this parliamentary commission on strong generation policies and economic development to review all the existing laws and policies to remove barriers to healthy aging, such as continuous working until old age. Okay, so and the first thing, what needs to be done? The first thing would be about the education of health professionals about the social determinants of health. The second thing is the monitoring about policies in those fields which will support health equity. And in the Europe and in US, they are doing the monitoring of policies in the other field. This is the main task of Healthy People 2030. In the US, they are monitoring education access and quality, etc. So you can see that's what health sector is doing to leverage the collaboration of other sectors. And for health-related associations, what can we do to support our members? So, for example, education and training again, and then tools for your micro-level interventions, such as clinical tools for social prescribing. That's the American Academy of Family Physicians are doing. And they also advocate for policies that encourage health equity. That's what I'm saying, that we need to leverage our influence. And this is what American Hospital Association is doing. They have these 6 levels of transformation for hospitals to improve your capacity, to help improve health equity. I will not go into the details. So my final recommendations, first, according to co-benefits rule, what you are doing is not only good for health, but also good for the planet and good for sustainable development. Sometimes we need to articulate your contributions in that way so that politicians understand better your value. You are not asking more expenditure in health. You are contributing to, for example, lowering the carbon emission. I hope they can pay you for your breastfeeding services, healthy eating service, plant-based diet, green transportation services, which means you are helping people to take public transportation to increase their physical activity. All these contribute to lower carbon emission. I will call them. You are doing these climate services. I hope they will pay you because now they are getting the carbon tax and carbon free. I hope they allocate some budget to support you. And for our network, I think we need to improve our literacy on health determinants, not only among the leaders and the health professionals, but also we speak with politicians, with decision makers to improve their literacy, not the usual health literacy. It's the literacy about health determinants. And we can leverage the power of data. Let data talk. So using your data, why your patients couldn't achieve good control in their cardiovascular health because of the environments, because of the high salt food provision environments. So you speak with them and you leverage their support to change the upstream conditions. And for our standards, some speakers also mentioned that actually, I think minor revisions might be needed, but generally speaking, the framework and our target areas, which include the communities, I think all these are very good. But we need to, for example, expand our focus from individual to individual physical and mental health to equity and well-being of our people and our planet. And also, I think in the care process, as you have seen, during the assessment, we need to include social assessment. During the intervention, we need to include social referral and social prescribing. And we need to work with the community, of course. And then finally, I just heard that next year there will be no HPH conference. The next one will be in 2026. If you would like to meet one another, each other next year, welcome to the 2025, the 25th International Union Health Promotion Education Conference. That's the World Conference on Health Promotion. It will be held in Abu Dhabi, and International Union for Health Promotion and Education is the professional association which WHO designed as its official partners. So we will talk about all these health determinants, and you are welcome to join, to register, to submit your abstracts, and to attend this 2025 World Conference on Health Education. Thank you.
Thank you very much for your energetic presentations and passionate statement on strategies and objectives to go way forward. Thank you. We are running out of time, but I think I can only take one question if you have, or comment.
The audience is very silent.
Okay, then please give us her a round of applause again. And Marianne, could you take over?
Yes, thank you so much for these two keynote presentations that were amazing. We're going to move on to the next part of this plenary session, which is a panel discussion. And for this panel discussion, we have the great pleasure to introduce you four distinguished speakers. I will ask them to join the stage so we can go on with the panel discussion. So Professor Katsunori Kondo, who is the CEO of the Japanese HPH network and co-chair of the scientific committee for this conference. Professor Oliver Groen, CEO of the International HPH Secretariat. Dr. Walter Fonseca, from the WHO, Technical Officer for Health Systems and Quality of Care in the Office of Athens. And finally, Dr. Ralph Farlid, who is the National Coordinator for the Swedish HPH Network and chair of the International HPH Network. While you are taking a seat on stage, just to let you know how this panel discussion will take place, we suggest to each of the four speakers that you have in front of you to choose one key message that they really want to share with you. Those key messages are both to wrap up the 3 days of this very rich conference, but also to open some perspectives and to give you some ideas, some solutions that might be good ideas to keep moving forward for health promotion, especially regarding equity issues. Please, can I ask you, Professor Katsunori Kondo, to go on with the first statement?
Based on my experience, I think the HPH network have 5 important roles. The first is monitoring health equity, the first role. When I became aware of health disparity was in my practice as a physician. It was not evidence-based, but an intuition based on my experience. In other words, not quantitative, but qualitative information. Because at that time, government statistics did not publish health status by income group in Japan. So it was believed that there are no health inequality in Japan, or if there were, they were small. Then the first things HPH network should do is to monitor health equity and inequality. Correct recognition of the real world is the basis for collaboration. After 14 years as a physician, I became a researcher. And when I conducted a survey, I found health disparity in Japan which could not be ignored. But I couldn't imagine how to tackle on health inequality. At that time, I met this international conference. I participated in 2010 conference held in Manchester. The topic is health disparity and social determinants of health. I learned many good practices in the world, in particular about advocacy. I was so encouraged. Then second important role of HPH network is making many good practices and disseminating them. And the third is education, training, and advocacy, as Professor Cho pointed out. We carried out health promotive community interventions to try to reduce health disparity in Japan, and we presented the process of the activity at the academic meeting. But we were asked, does it really have any effects? Then we, HPH network, also need to create and accumulate the evidence of effectiveness of health promotive activities or programs. I believe this is the fourth role of HPH network. The last fifth role of HPH network, as Professor Cho pointed out, to facilitate synergy or collaborations. I think there are two kinds of collaboration. One is between practitioners and researchers. Another is intersectoral collaboration. This month, as HPH member hospitals in Japan donated money, an endowed chair for the department is open at Kyoto University. Congratulations. In addition, me and another Professor Kondo, Naoki, at Kyoto University established a new initiative for co-creation of well-being and health promotive society. We aim to co-create a platform that brings together different sectors of industry, government, academia, and civil society. I would like to say, evidence or challenging practice without implementation is vain. Only advocacy or practice without evidence and intersectoral movement is not enough for implementation. We need collaboration between practitioners and researchers, and also intersectoral collaboration beyond the health sector to realize health equity. Thank you.
Thank you so much, Professor Kondo, for those inputs. Can I ask Professor Oliver Groen to go on with his own key message, please?
Yes, thank you very much. And I want to pick up where Professor Kondo left about the intersectorality, because I've been thinking the last 2 days about this conference, and we had discussions with colleagues about where should HPH go next, and the key topic for this plenary is also where should we go beyond the healthcare sector, and what is the next direction for HPH? Because while the program was really great and informative, I think it's true to say that a lot of the ideas that we discussed were not invented yesterday. Some of these ideas have been around for quite a while on the determinants and other concepts. So I think it's that's one reflection that made me think for today about what could be one of those next steps. That is accompanied with another observation that I had of the presentations that I've seen, and also the plenary discussions that I've been able to chair and that I've listened to. And I think, in my view, in my observation, a lot of the solutions that we presented and that we discussed today and the last days were fairly low-tech and high-touch. We talked a lot about social prescribing and community participation, and I'm a strong advocate for that. Don't get me wrong. I entirely support all those great projects that were presented. And a lot of the work that I've seen and listened to is really based on compassion and empathy and the personal relationship of doctors and nurses with their patients and with the community. And that is a very strong message and very reflective of what the HPH community stands for. But, and Professor Shutu mentioned that also, you used the term, the work is labor intensive. And I think that's correct to say that a lot of what we presented requires a lot of personal resources, highly qualified personal resources, a lot of contact time possibly. And that really made me think about where could we be going next. I'm attending other conferences as well. I'm not just a researcher, I'm also involved in other activities. And there are three terms that I think I completely missed them these 3 days. I haven't heard them. Maybe they were discussed, but I haven't heard them. And these three terms were big data, digital health, and AI. Sorry, I have to laugh because it seems a little bit out of place to talk about it, but exactly for that reason I'm mentioning that. Let me explain. I haven't seen anything about big data. What is our big data in healthcare? We have claims records and we have got some surveys in clinical medicine. We've got genetic testing and sequencing. That made me think, what is our health promotion big data? Can we live completely without big data? Is it just personal touch that we are building our work on? And when you talk about big data, there are these 5 V's. There's the volume. Okay, we've got a lot of clinical databases. We've got value. It's data that is meaningful. Variety. It varies by patient. Veracity. It is valid. It can be checked. But we haven't got velocity. There's not a lot of velocity in clinical data and certainly not in health promotion data. So maybe one of the things that we should question ourselves is, do we need health promotion big data? What could that be? How could it be leveraged and used? The second point on digital health, wherever I go on other conferences, there's usually someone holding up an iPhone with the latest digital health app. And I'm luckily a fairly healthy person, but I've got 5 apps on my phone that are health related. So that is a question then, how can we ensure that in terms of equity, we address digital health literacy to ensure that the gaps that we've observed so far are not even widening further, because well-educated, well-off persons can download all fancy apps on their phones, and not everyone else can do that. So we need to address digital health literacy, and there's great work by WHO and international organizations in that field that we haven't discussed these days here. And then the last point on AI. Can I ask for a show of hands, who hasn't used ChatGPT? Who has not used ChatGPT? No one is raising the hand. And ChatGPT is just one form of AI, of large language models. I wonder, could we use that technology for health promotion? What about communication, about rewriting tools, messages, or informing our messages to specific target groups, rather than saying we train professionals in one way to communicate and educate about a health issue? We can instantly adapt it to individual profiles with large language models. So that brings me to the conclusion: big data, digital health, and AI. It's probably not what people expected to hear, but I think we need to have a stronger involvement of the tech industry. And with the tech industry, perhaps in the next years, we can think about whether it's useful to explore these 3 ideas that I mentioned, or whether it's all nonsense. Thank you very much.
Thank you, Oliver. Dr. Walter Fonseca, can you please go on with your message?
Thank you so much for giving me the floor and to invite me to be here in this plenary session to share some thoughts on how we can move forward. And it's very interesting that you just mentioned how digital and machine learning and AI is invading our world, or it's already here living with us, because this clearly shows one of the messages that I would like to share with all of you. We really lived in a different reality nowadays when we compare with some decades ago. So this is, I wouldn't call it a new world, because it's us that we are building it, but it's for sure different. And we are still using policies and strategies that were thought for a different society. So when we look back to some years ago, we clearly see that we achieved a lot in terms of health indicators worldwide. And we also need to address that we also, as a society, as a global society, we achieved a lot. Many outcomes regarding health and regarding welfare improved in the last centuries in an unprecedented way, and we should be proud of it as humankind. However, probably this is not enough, and this is why we keep discussing how we can do better, how we can improve. And one of the most striking conditions that we have nowadays is about equity. And equity probably has two dimensions that I would like to highlight. One is the common perception that we have disparities in health due to social, commercial, economic, education determinants. We are all aware of that. But also there is disparities in data collection. So it means that we are always biased when we are doing policy because we have some data. We don't have a data set that covers everyone, that covers all the segments of the world, all the segments of the population. So when we talk about disparities and inequalities, we are talking about the outcomes, but also the things that we use to make policies. And imagine doing policy without the correct set of data. The policy by default will be biased to the data that we know. So the question now is how we can move forward. What are the solutions that we can discuss and advance? And I would also, before closing, to share probably three things that I would like to give for your consideration. One is definitely that we need a broader vision of health. It's not anymore possible with the data that has been showed by the second keynote to look to health just by a care provision concept. We know that the determinants have a huge impact, the behaviors, the cultural aspects. So we need actually to expand a lot the way we look for the way we do health policies and the way we provide care, the way we incentivize health promotion and disease prevention. And this probably connects with the first speaker as well of this plenary, because it touched that we need to revise the curriculum for having better education in a more broader perspective, and also touches the intersectoral approach that we need. So we need to think broadly, and we need to consider all aspects of health. The second topic that we need probably to address in a careful way is data and evidence. We all know from many different sources that without data it is really hard to move forward because we don't have a starting point, we don't know what to improve, and sometimes we consider that we know but we don't. And it's better to decide based on data and not on perceptions, although perceptions are quite important as well. So data needs to be really in the starting point of the way we can move. And last and probably more important, we need to refocus even more in the digital era in people. And when we talk about people, we don't only talk about the patients, we talk about everyone, because the health sector is about people. People that are sick, people taking care about other people, and people working with people. So it's all about people. Focus on people, on promoting the health, well-being of everyone involved in the system will definitely be one way to move forward. And I would like to conclude with an optimistic tone. We know today much more than we knew in the past, so I think it's our commitment to do better and better. Thank you so much.
Thank you very much for those optimistic words that we need. And to finish with this panel discussion, please, Dr. Ralph Harlit, your words.
Thank you very much. while listening to my colleagues here, I suddenly realized, and I'm a bit embarrassed, that there are 4 men sitting up here. Now that's a note to the organizers. Next year there will be 2 women and 2 men, or at least 4 women, I think. But sorry for that. But I would like to thank Professor Nakayama for his clear description of Japan health care system, and Professor Chu for your comprehensive overview of the role of HPH networks. And I think that through these presentations, we are reminded that the pursuit of health equity, which is the theme of this conference, extends beyond the walls of hospitals and clinics, and it requires a commitment, as was pointed out, to address the broader social, environmental, and economic factors that shape health outcomes for individuals and for communities. And I believe this is the true essence of what health-promoting hospitals and health services aim to achieve: to advocate for policies, to foster intersectoral partnerships, and act as catalysts for systemic change that benefits all, especially the most vulnerable. Within the healthcare sector, and I work as a healthcare worker, we usually face the symptoms of inequity firsthand, that we see the inequity. We deal with that, as I pointed out yesterday on Plenary 3, in a rather reactive way by continually adapting our systems, our healthcare systems, to meet the growing needs of populations affected by disparities rooted in social isolation, environmental risks, or economic inequality. But we will never catch up doing it that way. I would like to quote, and we saw Sir Michael Marmot in his latest report, Build Back Fairer. He stated, "What good does it do to treat people and then send them back to the conditions that made them sick?" To tackle these root causes effectively, we must engage policymakers to create supportive frameworks. We must engage local governments to build inclusive infrastructure and educational institutions to promote health literacy. The private sector, including employers and the food industry, can also drive change by fostering health-supporting workplaces and ensuring access to nutritious food. And collaborating with community organizations, especially those representing underserved groups, will further strengthen our efforts to ensure they reach those who need it most. And our responsibility as HPH networks extends beyond adapting healthcare alone. It is our duty to open the eyes of other stakeholders and inspire them to address the root causes directly. Achieving health equity cannot happen in isolation. It requires the involvement of and collaboration with other actors. And I think that our networks, not only the international HPH network, but the networks in each country, must not only provide equitable care, but also become global leaders in education and advocacy, empowering communities and stakeholders to influence the policies that have an impact on health. And I would say by mobilizing, and listen now carefully, Oliver, big data, by mobilizing big data and on health promotion and fostering literacy on social determinants among healthcare professionals, as have been pointed out here during these presentations, we can pave the way for healthcare models that are inclusive, proactive, and sustainable. And I will conclude with, at yesterday's Plenary 3, I realized that I expressed a certain amount of resignation to this task. I I was said by Dr. Chu, who said, I believe in the future, we can do it. And I must say that deep down, I truly believe that together we can transform our networks into models of social responsibility, demonstrating that health promotion is not only about treating illness, but about creating enabling conditions for healthier and more equitable societies. Thank you very much.
Thank you so much to the four of you for those words. Maybe before just summarizing those messages, if the floor wants to share a comment, it is the last opportunity to do so. Yes, we have a question. Please, can you introduce yourself before asking?
It's Fran Baum, and I've enjoyed all your presentations, and I think what we've seen in this conference is there's lots and lots of evidence for health promotion, but what's lacking very often is political will, particularly for the intersectoral work. So what ideas do you all have about how we can create that political will to actually invest properly in promoting health?
Do you want to react? Yes.
Well, to go back to actually what I was trying to say here is that I think that we working with the patients and the symptoms of inequality in society, we need to scream louder. We need to make the politicians and the policymakers more aware of the root causes. That's the best answer I can get. And I know it's a tedious work, but by trying to do and fix this problem ourselves, I don't think that's a profitable way.
Thank you.
Maybe I can just add to that. From my work, I see it slightly differently. I agree that the political support could really accelerate our work. But what I also see is that often when I speak to hospital managers or healthcare system managers, they know what the problems are, they know what the solutions are, but they're not given sort of the leeway, the creativity to actually adapt local solutions because it's not allowed. You need to follow a sort of one-size-fits-all approach to care organization. And I think if we were given the managers of local health systems more freedom to live out their creativity, address these local problems, I think we could move much faster as well. It's a slightly different point, but it reflects definitely my experience. Thank you.
Thank you. Do we have one last comment? From the panelists, maybe? One last word from you?
Thank you for the question. The question is quite important, and I think it's one of the ones that we always have in our minds. I agree with my colleagues in the panel that I think working with patients, it's critical because they can demand more from the policymakers because in the end they are the voters. However, I think there is also something that we need to probably invest more in the research community, which is how we can show that we are going in the right path with short-term indicators, because one of the challenges in promoting health is we need to wait a huge amount of time to show very impactful results, and this is usually lagging behind the time of a political cycle. So I think if we can find ways to show that we are obtaining short-term results that can be work as a positive feedback is also very important, because this is one of the questions that sometimes we heard from the politicians is, but in 2-3 years, can I see results or not? Thank you.
Thank you very much. I think yes, Ralph, you want to add something?
I would like to comment on this also, because I believe we have some evidence, or we have a huge amount of evidence, that health promotion, not to say prevention, but now we're talking health promotion, actually is good for the individual and for the community. But I believe that also that we are fighting not only, or fighting, sorry, I agree with you, there is an awareness amongst politicians, but we are fighting against the enormous demands here and now on healthcare, on healthcare, on sick patients. And that's probably a part of the demographic change. And of course, it's difficult for politicians to, in that context, say, we don't invest so much in you who are ill. We are investing instead in those who are not yet that ill. So it is a challenge, but together we can fix it, right, Chu? Yeah.
Thank you very much. I will just try to summarize your 4 main ideas that we just have during this panel discussion. So the first point was about the background. I think that we have to consider that we already achieved a lot, that the things change already, and that we still have anyway to tackle some burdens, which you mentioned, like inequalities or biased data collection that are thus putting in question the project that we are putting in place. We have also to keep moving forward thanks to different levers like engaging stakeholders, but also being global leaders in health promotion, also thanks to the different network in every country with health promotion. You also mentioned that we have to keep in mind that several questions are still here, like the place of AE or data and digital world, everything we have to keep in mind to go on. You also remember us how important it was to base our work on data, but also on good practices, on evidence-based program, everything that we can very strongly have like a background of our work. That this is very important, and I think that behind all those very practical aspects of levers or burdens to tackle, we have also a spirit to share, spirit to have the people in the center of all our work. And you mentioned that it was not only patient, but everyone, people in general. And I think it was very important, and it was also linked with the importance of relationship, intersectionality, and the empathy that we should have regarding the people we are working with. That was, I think, the main ideas that you offered to the floor with this panel discussion. Thank you to the 4 of you for these very interesting key messages that are closing the plenary session in the best way, in an optimistic way, I think, which was important. Thank you also to the keynote speakers that were there at the beginning of the plenary session. And just before closing, do not leave the floor, because we will now have the poster award session and then the closing remarks. Thank you for attending this session.
Yes.
Yes. Of course. We have an important question. Did someone found a laptop because a laptop was lost? If anyone found a laptop, please bring it back here or at the reception, but yeah, please let us know.
morning to the awarding of the prizes for the best posters. And we have two sets of prizes, three from the International HPH Conference Secretariat and three from the Japanese Organizing Committee. And I'm very happy to announce the first winner. But before, what is the prize? The winners will receive a certificate and will be also featured on the conference website. And I'm sure you will spread them also via social media and so on. So the first winner is poster number 222. It's titled Enhancing Mental Health Services for Children and Adolescents with Mental Illness in Taiwan, a community-based intervention study from 2015 to 2021. Yuchu Shi is someone here who can take the prize. We will, or a colleague from she or another one who can take the poster prize with her. No matter, we will send it via email, and we come to the second poster. It's number 275, Body Composition and Grip Strength Changes after a 12-week physical jogging program for health professionals in a medical center in southern Taiwan, pilot results of the BCGC program. Wenchuan Shen. Okay, I've heard earlier that many participants from Taiwan already left and are on their way back home, but we have also prepared emails, and they will know that they will receive a prize soon. So, the third poster, it's number 407. Surprise, surprise, it's also from Taiwan, and it's titled Community Health Promotion Initiative Starting from Hospital Restaurant. Wen Yi Hu, are you here and can take the prize? Please come to the stage. Great.
Can I represent our network to?
Yes, please go.
Congratulations from Japanese committee. Congratulations.
The other two I can help to take too.
And take a photo.
Okay, take a photo.
Congratulations.
Thank you. I will take two. All right.
After two.
Two. Yeah.
Oh.
I will, yeah.
Congratulations.
Thank you. Okay, thank you.
Congratulations.
Congratulations. Just to confirm, I'll create a special award for only Japanese. I'll introduce a Japanese committee's presenter, Dr. Negishi, moving to the stage.
First is O. Kakugun, Chiba University. Is there? O. Kakugun-san. Congratulations. second winner, Noguchi Ai in Shield Hospital. Congratulations. That's all. おめでとうございます。Third winner, 笹原正幸、国際医療福祉大学。Congratulations.
So, on behalf of the Japanese organizing committee, I will deliver the closing remarks. Dear colleagues, thank you for attending the International Conference on Health Promoting Hospitals and Health Services in Hiroshima. How did you find the conference? Thank you. Thank you. For international participants, I hope you had the chance to have a good Hiroshima delicious food, especially okonomiyaki. We welcomed around 800 participants from 34 countries and regions. I want to express my sincere gratitude to everyone who took part. This is the first time that the International HPH Conference has been held in Japan. We started preparation 2 years ago, forming an organizing committee with the support of leading figures from Japan medical and research communities. This enabled us successfully hold this conference. In this conference, we aimed to discuss how health promotion contributes to addressing widening global health disparities. With this goal in mind, we set the theme of the contribution of health promoting hospitals and health services to health equity. Over the 3 days of discussion, I believe we have found concrete ways to contribute to health equity as HPH institutions. I hope all of you take these valuable outcomes back to your own facilities and spread the impact for further. This conference's achievements were made possible by the extensive cooperation and participation of many people. I would like to express my gratitude to the following participants. First, I'd like to express my appreciation to Brigitte, Julia, and Astrid from the International Conference Secretariat in Vienna. Thank you. They guided us with patience and care as we navigating hosting an international conference for the first time. Next, I'd like to recognize the Japanese Organizing Committee Secretariat, Kato-san, Tokema-san, Hirota-san, Ikeda-san, and Itamoto-san. They responded promptly to my sometimes unreasonable requests and skillfully managed the practice preparations. I want to acknowledge that this conference success rests on their dedicated efforts. Lastly, as you may know, next year marks the 80th anniversary of the atomic bombings in Hiroshima and Nagasaki. And there is a message that I'd like you to take back to your countries to ensure that the tragedies that occurred in Hiroshima are never repeated. It is a message shared by Hibakusha, Mr. Senji Yamaguchi, during the United Nations Disarmament Special Session in 1982. It is also a message that aims to achieve peace, which is a fundamental prerequisite for health promotion. No more Hiroshima, no more Nagasaki, no more war. I look forward to seeing you next conference. Thank you. ありがとうございました。
I truly admire your patience. But distinguished guests, speakers, poster authors, and delegates, it's a great honor for me to both be able to open and close this inspiring and successful conference. And reflecting on the past few days and after the emotional opening of this conference, I can state that we have explored topics fundamental to the future of health equity, and that was the aim of the conference. As we come to the close of the 30th International Conference, I would like to extend my heartfelt thanks to all who have contributed to make this event such a remarkable success. I want to thank the Japan HPH Network, Dr. Funakoshi, and all your co-workers. I don't know them by name, but there are a lot of them. And together, of course, with the International Conference Secretariat, Christina Dietscher and Birgit Metzler, and all of your co-workers who together, for your tireless efforts and dedication that bringing together such a powerful and inspiring gathering here in Hiroshima. A deep thank you to our speakers, our panelists, and our poster authors. Your contributions, your research, your insights, and shared experience are essential and have shaped this conference into the success it has been. Through your presentations and discussions, you've helped us dive deep into complex, multi-layered landscape of health equity, and each of you has brought us a step closer to understanding what an equitable healthcare system might look like. And last but not least, to all you delegates, thank you so much for your active participation, your questions, and your engagement, because without you, there wouldn't be a conference. Conferences like this are as much about learning as they are about forming connections that last beyond these few days, creating a shared commitment to the principles we have discussed here. Now, before I conclude, it's my great pleasure to invite you all to the next conference. The HPH conferences have traditionally been held in springtime, and we aim to return to that order for the next conference. And that means we will probably not have a conference in 2025 because spring comes quickly. Maybe not quickly enough if you live in Sweden because it's quite cold during the winter, but it's too quickly. So we hope to welcome you to the next conference in May 2026 in Sweden. Where we will continue to build on today's discussions and further our efforts towards achieving universal health equity. Once again, thank you all for your time, your passion, your contributions to this year's conference, and I wish each of you a safe and pleasant journey home or wherever you're heading, and I look forward to seeing you soon again. Thank you very much.
Please, everyone from the organizing committee, from the Japan organizing committee, and also from my team, from the conference secretariat, it would be great to have you here on the stage, and if you can applaud. And Andreas, you too.